Okay, good morning, everyone. It's my pleasure to introduce our speakers today. It's our own Drs. Crowe and Dr. Henkel. Many of you know these wonderful physicians and leaders, and I'm just going to take a minute to highlight a couple of their wonderful accomplishments and contributions. Dr. Susan Crowe is a clinical professor here, an OBGYN at Stanford. She's really focuses on obstetric and lactation medicine patients and has really been a leader in transforming maternity care practices here at Stanford. She led the breastfeeding initiation for skin to skin during vaginal deliveries and C-sections. And she works as a leader in Well MD at the Lactation Council, where she really did groundbreaking things to remove barriers for lactation for physicians and scientists as they return to work after childbirth. And beyond this amazing institutional work, she just gives attention to each individual, within our own faculty and staff. She's just makes sure everybody is able to achieve their goals as best they can. And then Dr. Andrea Henkel is a clinical assistant professor and complex family planning specialist here at Stanford. Many of you've known her. She's did her training here and has now launched into a faculty career with amazing research programs and mentorship and advocacy. Her research interests focus on second trimester abortion, evidence-based practice and policy, really centering the patient experience. And she served on the ACOG as the California Junior Fellow Legislative Chair during residency and has worked with AMA in their advocacy space, and now serves as the ACOG delegate to the California Medical Association and is on the ACOG National OBGYN PAC Governing Committee. I could go on and on about these amazing people, but I'm going to let them speak about this really important topic. Thank you for being here.
Good morning. Thank you for this opportunity to present. We'll be presenting lactation support and suppression, caring for the full spectrum of pregnant individuals.
I think you want to swap your displays.
Oh, thank you. Yes, you. Nope. There we go. Thank you. We have no financial conflicts of interest. However, we will be discussing multiple off-label uses of FDA-approved medications. We also just want to start this out with saying that we are both parents and obstetricians that support breastfeeding policy and accommodation for lactating people, but we also acknowledge that this topic can be hard for those who have struggled to breastfeed when they wanted to, those who are unable to become parents, or those who have experienced lactation without a live-born infant. We also are hoping to create a really inclusive approach to infant feeding and acknowledge that many of our patients may prefer multiple or different terms, breastfeeding or chest feeding, breast milk, human milk. Ultimately, our goal is to support all people with their infant feeding goals. So today, we hope to describe the benefits of breastfeeding and how the obstetrician can support lactation initiation after birth, recognize and address common issues that may arise in the breastfeeding dyad postpartum, and then support patients after later abortion or pregnancy loss with lactation goals using an options counseling framework. I will start with the physiology of lactogenesis. I know that many of us don't think about this on a daily basis, but stage 1 lactogenesis starts around 16 weeks gestation. People experience relatively high levels of estrogen, progesterone, and prolactin that stimulate the anatomic growth of the breasts. While prolactin levels are high during this time, they are inhibited by the high levels of progesterone. Stage 2 lactogenesis occurs after the rapid fall in progesterone after the placenta is removed that removes this antagonizing effect of prolactin. The baby suckling sends sensory impulses back to the brain, to the anterior pituitary to secrete additional prolactin, and to the posterior pituitary to secrete oxytocin to express milk. In the absence of physical stimulation, lactation does eventually stop.
So here I'm briefly going to highlight that when we think about lactation and we think about the health impacts that may be short and long-term on both the parent and the infant, and that we do still struggle with some very big differences in terms of lactation rates throughout the first year. And at the first year, I just want to highlight between non-Hispanic white, non-Hispanic Black, that these numbers here are very different. And so a lot of work still to be done. And this is also a little bit regional, just to see here that, at 6 months, the darker areas are breastfeeding at a much higher rate than some of the states over in the South. So the culture here is very different than other people may experience throughout the country. And the AAP did change their policy in June of 2022 with the recommendation of breastfeeding exclusively for about 6 months, followed by continued breastfeeding as complementary foods are introduced, with a continuation of breastfeeding for 2 years or longer as mutually desired. This is something that even I, as an advocate for lactation, I'm having to think about how to integrate that into my counseling of patients, because part of this policy statement is to help us set up the support structure so people can continue breastfeeding for 2 years or longer. But I don't know that our society is as supportive of that process as we need it to be. And Andrea will be talking about that.
I always love talking about legislative history, so we will go through lactation legislative history. So lactation support really started out in the States, and the first state to introduce lactation accommodations was in 1984. Like, this is not very long ago, actually. And that was New York, and that exempted breastfeeding from public indecency offenses. It followed in 1993 by Florida and North Carolina that permitted breastfeeding in any public or private location. 1994 in Iowa was the first state to allow lactating individuals to postpone or be excused from jury duty. In 1998, Minnesota required employers to provide a break time in a private space to express milk. And in 1999, Hawaii prohibited employers from discriminating against an employee expressing milk in the workplace. Many states followed thereafter, but still, this is really recent history where states have taken a proactive approach to protecting lactation. With regards to federal policy, this is even more recent history. In 2010, when the Affordable Care Act passed, it amended the Fair Standards Labor Act, the FSLA, to include a section called Break Time for Nursing Mothers that requires employers of hourly wage earners to provide break time in private space to express milk for 1 year after the child's birth. Not many people are wage earners. Most of us are not on this presentation today. So many people were excluded from this, though certainly it was a start. In 2016, the BABES Act passed. Many of these have like great acronyms. That allowed for formula, breast milk, and juice for infants and toddlers to be brought through TSA screening checkpoints of greater than 4 ounces. In 2023, the PUMP Act passed, which expanded coverage from the 2010 FSLA expansion. So now it includes salary workers, so all of us, and with those same protections of private space to pump and break time. And it also clarifies that pumping time counts as time worked when calculating minimum wage and overtime if an employee is not completely relieved from their work duties during the pumping break. And it also finally gave kind of a enforcement mechanism by allowing an employee to file a lawsuit against an employer that violates this law. In 2023, the Pregnant Workers Fairness Act primarily requires workplace accommodations for people who are pregnant, but it does also extend into the postpartum lactation protections with regards to having an employee ask for a temporary transfer to another position if they're exposed to environmental hazards or chemical hazards, as well as modifications to a uniform or equipment to be lactation friendly. California, relatively supportive. In 1998 was when state legislation protected the right to breastfeed in public, which again, very recent history. In 2001 is when we allowed people to get a year of jury deferment. In 2019, State law protects people asking for accommodations beyond the 1-year mark, so this expands beyond what is federally protected. 2020, we are people who are incarcerated in county jails have the right to express milk and have a space and way to do so. As of 2024, breast pumps are now tax exempt in California, notably infant formula already was exempt. And as of 2025, all perinatal units must adopt this 10 steps to successful breastfeeding as adopted by Baby Friendly USA or a similar program to support lactation, which is going to jump back into Dr. Crowe.
All right. And I just want to add that Stanford Hospital, Lucille Packard, they have taken things a step further as of September 1st of this year to offer work RVU credits for people when they block their clinic for lactation time, and that they will funnel funding into our departments as people return from work who are needing time to lactate. So there are some departments that are heavily reliant on that. But regardless of what each department decides to do, that will really impact the culture. So I'm going to race through some of these slides. I want you all to know that today I'm going to talk a bit about the visit that we have. The Baby Friendly Hospital Initiative requires an accreditation by the organization Baby Friendly USA. And there have been many steps that we've taken over the last couple of years to bring the information that you all need. And the purpose behind this is much to help address the disparities in lactation support that have occurred across the state and access to that support. So during the interview, there will be 5 providers interviewed. They will interview our patients, prenatal, antepartum, postpartum, and also patients whose babies are separated on other units. So just so you know that our patients will be asked about the care we provide. So the language that they've used in the booklet, the study guide, I will send out to you. The language is not as inclusive, and we've tried to change some of the language to make it inclusive. But there are most of their information, it refers to the word breastfeeding, but we really want to include the language that our patients prefer. So the question will be asked, describe why breastfeeding is what they will say is important. And we want to know what the World Health Organization aligns with the AAP in recommending lactation for 2 years or more. And the microbiome of the baby who is receiving human milk only is much different than the microbiome of a baby who's receiving other types of milk. So in any case, just want you to be able to describe that. And then they also, I changed this language a little bit. They talk about the increased risk of not breastfeeding, but I prefer to use until our society has reached a point where everyone gets the support that they need. I choose to use the language decreases the risk to make it sound a little less frightening to people. So it can decrease the risk of these things on the left here. Certainly for our preterm babies, necrotizing enterocolitis, especially now that we offer human milk that's been pasteurized and donated from other people through the milk bank of San Jose, the rates of necrotizing enterocolitis are so low. But important to realize is that beyond the infant, there's also a decrease in the maternal risk of particularly some of the things that we see: breast cancer, ovarian cancer, hypertension, diabetes. And I always talk to my prenatal patients who are diabetic, that this is like almost like a miniature vaccine. And so the next question, describe how you would assess a pregnant person's knowledge about chest or breastfeeding. Asking, what have you heard about it? What have you heard about how to get started? Asking these questions. What have you heard about skin to skin? And asking these questions. What do you know about colostrum? And so here's describe why exclusive human milk feeding is important. Human milk feeding at the breast or chest the baby will learn to feed. They'll learn to self-regulate. It'll give them the nutrition they need. But knowing that colostrum is rich in protective factors, and it also helps to eliminate the meconium. And so, these are some of the things we mentioned also about the microbiome, but it will also, it'll help develop the supply that is needed. And reasons why skin to skin should not be delayed or interrupted. So we're so grateful to be at an institution now where this is routine. But immediately we see differences. We see more secretion of the oxytocin and endorphins for the parent. Baby's cortisol's level will be higher if it's delayed, and a higher level of stress, and better temperature control. And it was interesting when we initiated skin to skin initially, we noticed that babies weren't crying as much, and it made us nervous. We're like, baby's not crying. We want babies to cry. But when we look at this, it also can protect and this decrease in cortisol, and it can protect the infant's glucose level as well. So, on the right here, that's not skin to skin. And for many years of my initial practice, I thought if, the cheek of the baby was touching the mom in any place, that they were skin to skin. But this is a picture here on the left of one of our patients who wanted to share her experience with all of you. And that latch is amazing for a newborn. All right, so skin to skin, this is like one of the few randomized controlled trials that has taken place related to lactation. It's hard to find RCTs, but this one here, you can see that in the early skin to skin group versus the control group that was not skin to skin, these increases in breastfeeding rates as time went on at 48 hours and at 6 weeks, it demonstrates how much skin to skin can help. There are medical reasons to delay it, and they may ask about that in the presence of a critical medical issue, and if the parent's not well or the baby is unstable. And certainly there are reasons to delay or interrupt it, that the health of the parent is critical. And in terms of why is suckling at the breast chest in the first hour important when the baby is ready, and just that it can trigger the production of milk, facilitate lactogenesis. And I have found, and I have not found studies on this, but we know that the body releases endogenous oxytocin, and it just seems extraordinarily powerful in terms of bleeding and uterine contractility. And parents learn to recognize the cues. There is an international code of marketing, and I'll say here briefly that we cannot demonstrate any kind of advertising of formula companies. And this may seem routine now, but back when I had a baby, there were 2 companies that sent me a year's supply of formula. So I think that this is an important piece of the baby-friendly initiative. First 36 hours to 4 days, Babies feed frequently. I would say minimum, here they say of 8 times per 24 hours, but it's likely going to be much more frequent than that. And we want to make sure that the weight stabilizes by day 4 and that the stool is changing from meconium to more yellow. And what have we done to help in-service training? You've had the privilege of doing a health stream course that I hope you thoroughly enjoyed. The maternal and infant risk factors associated with delayed lactogenesis. So if there's insufficient glandular tissue, flat or inverted nipples, which hopefully have been discussed with a patient in her prenatal care, delivery problems. You can see all these things here. If the baby is of low birth weight, less than 37 weeks, these are all risk factors that are probably very obvious. Contraindications. For many years, HIV was a contraindication, but globally that changed on some levels. And briefly, there is a LPCH policy that aligns with the AAP changes that people can have the choice to breastfeed if agreed upon between the patient and provider. And these are obviously going to be people who are very successful with their viral suppression. But that's a change, and so important to highlight. And then, of course, inborn errors of metabolism. Medical indications for supplementing the newborn. We are fortunate here to have, like I said, the donated human milk, and we will start with that and offer that as a choice, which most people choose. Hypoglycemia, signs that their weight loss is beyond what we expect. High bilirubin, delayed lactogenesis, insufficient milk production. And there are people who their bodies are not set up to make an adequate milk supply. And it's important that we support people like that, both physically and emotionally. But saying that everyone can make enough milk is not, that's like saying if someone tries hard enough, they're not going to be diabetic, because if they really work on it, their pancreas will kick in. It's just, there are some people. Intolerable pain and temporary separation. So briefly, medications in milk. When we think about medications in milk, we want to think about, is the medication transferred into the breast milk? And if yes, what is the effect on the infant? There are things that there's a resource around here, Hale's book and I'll show it in a future slide here, but it depends on the molecular weight. If the molecular weight is very large, like a lot of our new biologics, it's often considered likely that it would be safe to use during lactation. So as new medications come up and we don't have all the data we wish we had, we need to be able to think about those things. And by all means, people do not need to delay lactation for CTs or MRIs with contrast. And this comes up more frequently than one might think, especially in the immediate postpartum time. There can be harm done to the relationship of lactation initiation if that's interrupted. So I've highlighted here medical references. There are quite a few. The Infant Risk Center is amazing, and it is related to the Hale's medications and mother's milk. We do have the current edition also in some of our maternity units, as well as in the OB clinic. So anticipatory guidance for calming or soothing techniques before, after, as alternatives to pacifiers. So there's a lot of debate, as you may or may not know, about the use of pacifiers, but they can interrupt some of that immediate initial interaction. And so these are some alternatives. Hold the infant skin to skin, offer the breast or chest again, that that there's not necessarily a time limit or a time to offer the breast, that we want people, to learn how to watch the baby for feeding cues. So what are high-risk populations that may warrant extra precautions to protect against severe infections associated with powdered infant formula? Infants who are 3 months of age or younger, infants who are premature, infants with illnesses or other medical treatments, such as chemotherapy for cancer. We want to make sure that we support the parents who are going to use infant formula and make sure that they know how to do it safely. And we want what are identifying early feeding cues and late cues. So crying is a late sign of hunger for a breastfed baby. So they usually will, they'll make movements in their mouth, they'll suck their hand, they'll make some vocal noises. But once they start crying, that's been a late sign of hunger, which is something that can be important to highlight. When to introduce the pacifier, usually after chest or breastfeeding is well established, about 4 weeks, and pacifier use may reduce the risk of SIDS. And that's why we certainly, the AAP is even recommending its use at a certain point. This is a trial that was done for diabetes and antenatal milk expression, called the DAME trial, that basically showed that if people want to hand express breast milk in late pregnancy, that it's safe and that it may help some people. I don't think there's enough evidence to say that everyone has to do this in order to breastfeed. I think that's not the case, but this is also something that may benefit some of our patients. And so we just want to know how to do it. And I often will show people in my clinic around 37, 38 weeks for people who have not delivered. But this is something to talk to our patients about as well. And they can store the milk and put it in the freezer. It is colostrum and it can be very helpful to some people. Okay, so in the early postpartum period, the feed really is only about 5 milliliters. The entire newborn stomach capacity is 20 milliliters. So 1 ounce is 30 milliliters. So we certainly don't want to be handing out a 2-ounce bottle of anything to people. And it's been really nice to see our nurses and addressing this. And I haven't seen I've seen them using really appropriate amounts of milk for people who need supplementation. And then just a little cue for all of you that this baby has its mouth open wide and that the nipple is deep in the mouth and up in the posterior area of the pharynx, and that this is a great position. And some people who are having pain, you just pull down on that baby's chin and have that lip go outwards, and it's amazing. So you can see this baby, this mother may experience pain unless she relatches her baby, and that nice open mouth, the lip is outward. And just teaching a parent to do that with each feed, within a couple of days, the baby will learn to do it on their own. I'm briefly going to touch on the changes that have gone on with mastitis. This is something that, just some clues about the spectrum. And once there is a cellulitis, it can spread. There's a new AAP document saying that, one can try treatments without antibiotics. But this is also, I want to highlight, some of our patients are actually very sick, and treatment initiation immediately may help to prevent an abscess, and the Diclox is the first line. This is a patient who was told to stop breastfeeding after her mastitis was diagnosed and developed an abscess that was quite painful for her and required multiple drainages. And then I just want to touch also on the fact that adoptive and non-gestational parents will can induce lactation, and that they should be appropriately counseled, and that I'm happy to see them in the obstetric clinic to discuss how to do that most successfully. Clearly, people who have previously lactated are have much more success in terms of that. And I just, want people to know that this exists, and that there's also a wonderful case report of a transgender female individual who was able to take medications to mimic the physiology that Dr. Henkel described, and was able to lactate.
Great. So I'm going to talk about lactation inhibition after abortion or pregnancy loss. To center this on the patient experience, there are multiple qualitative studies that describe the both physical and emotional pain of lactation after a loss. Breast engorgement and leaking can be seen as a reminder of the loss, and it's really hard sometimes for these patients to reconcile the motherhood identity associated with lactation with the absence of an infant. In one qualitative study, the patient said, "It was not only the physical pain that bothered me, feeling pain in my breast and knowing that there was milk and having no child to feed was agonizing." Importantly, in these qualitative studies, people universally did not expect to lactate. So therefore, they thought medication was unnecessary, which really just is a reflection of our counseling as clinicians. Another quote from a participant: "My heart ached as I woke every 2 hours with breasts engorged with milk and no baby to drink it. I realized my milk was going to come in whether I wanted it or not." This is my own study, and looking at people who are 18 to 28 weeks. And we found that nearly all people are symptomatic by day 4 after a second trimester loss or abortion. In adjusted and unadjusted models, we found no significant clinical associations between those who experienced breast symptoms and who are bothered. So it really emphasizes we should be giving this anticipatory counseling to all patients. We shouldn't be kind of assuming or guessing which patients are going to be symptomatic. So after a second trimester loss or abortion, I use my CFP hat around options counseling. And I really hope that we can, as a group, kind of use this model to help people both anticipate that this is a normal physiologic process, as well as what they should do with it, or what they can do with it. The first option is milk expression. This in qualitative studies has been found to be really helpful for some people, that the milk donation process helped bereaved individuals resolve their ambiguous loss. One participant said, "The process of donating milk was actually, or of expressing milk, was almost meditative. It was a time that I could relax and think about Archie, our son." So with milk expression, people can donate that milk. Minimum donation amounts vary by milk bank, and oftentimes are lower for those who've experienced a loss. Notably, there are many contraindications to donating milk. So it is important to screen the patient just to avoid disappointment of being able to actually donate the milk. And to the same extent, some anticipatory guidance around what does it actually take to express milk. This probably does mean waking up overnight to pump. This is, a commitment. Alternatively, one can create breast milk jewelry with as little as 1/2 ounce of milk. And that can be a really lovely way to remember the pregnancy for someone, in the study, of a loss or an anomaly. Great options. Option 2 would be supportive measures. So this isn't necessarily inhibiting lactation, but to help people through that time of engorgement. This concept has been around for centuries, using various herbal remedies, jasmine flowers, anti-inflammatory supplements. Unfortunately, in a Cochrane review, there really is no conclusive evidence that these non-pharmacologic interventions lead to a more rapid resolution of symptoms. I would put this into the category of things that probably doesn't hurt, maybe doesn't help. And I know many of us have heard about advising patients to use cold cabbage leaves. And in RCT comparing cabbage leaves to alternating hot and cold compresses, there were really neither of them were particularly effective. So this leads us to option 3, pharmacologic inhibition. And I think the timeline is important to review because many of us are at different points in our careers and have different experiences with the kind of concept of pharmacologic inhibition. So in the 1950s, lactation inhibition after full-term birth was often achieved using DES or high-dose estrogens. There are many side effects and multiple adverse events, as one can imagine, giving someone a high dose of estrogen postpartum. In the 1980s, the FDA approved bromocriptine or Parladel for postpartum lactation inhibition. And for most people, this was well tolerated. But in 1990, the FDA asked the manufacturer to voluntarily stop selling the drug as a lactation suppressant because of a few case reports of seizure and even stroke. Kind of importantly, this is probably at population level. From a drug pharmacology standpoint, there really is no reason that dopamine agonists should cause a stroke, if anything, cause hypotension. But there were a number of these events led to some lawsuits against the maker of Parladel. And ultimately, when Parladel was acquired by Gerber, they just voluntarily removed it from the market. So for a very long time, or in recent history, there were no pharmacologic options available to folks. And it's really actually quite recent in 2020, when the U.S. Health and Human Service Panel on Treatment of Pregnant Women with HIV Infection and Prevention came out and said that they recommended cabergoline for lactation inhibition for those who have contraindications to breastfeeding. So cabergoline being also a dopamine agonist that's a little bit longer acting than bromocriptine. Bromocriptine and cabergoline have been studied head-to-head in clinical trials, and the half-life of cabergoline ultimately results in more sustained lactation inhibition. So this leads to my own fellowship study. It's a MOC article this year, in case anyone hasn't finished up their MOC articles. Where we randomized people to cabergoline 1 milligram PO within 4 hours of fetal expulsion or procedure compared to placebo, who are 18 to 28 weeks gestation with a pregnancy loss or abortion. Importantly, the contraindications and exclusion criteria were those who had uncontrolled hypertension, severe hepatic disease, history of pulmonary, pericardial, or retroperitoneal fibrotic disorders. Most people can take this medication, but I do want to just highlight those with uncontrolled hypertension, which we included as anyone with a new diagnosis of pregnancy-induced hypertension were not eligible for the trial. And we found that cabergoline was really effective in preventing symptomatic breast engorgement. Which led us to our current trial that we are enrolling of people who are 16 to 20 weeks gestation. We had very few people who were 18 to 20 weeks in the original trial, just as a reflection of our quaternary referral status here. And we're enrolling here at Stanford as well as Planned Parenthood San Jose. So just, my own clinical practice, and, would love to hear how other people go about this, is I provide anticipatory guidance for all people who have a pregnancy loss or abortion after 16 weeks gestation. And I provide that information both verbally as well as in an after visit summary. And then I discuss with patients the options for pharmacologic inhibition, non-pharmacologic supportive measures, milk donation, or memory creation using human milk. And allow patients to really make an informed decision around this. Really, this is different than just checking the box for cabergoline on the preset L&D loss order form. I really think that patients need this counseling and should come to their own decision about how they want to manage lactation after a loss. And then I provide resources based on that patient preference. So that means dispensing cabergoline from the GYN clinic or here on L&D so they can take it in a really timely manner. We've had a hard time sending it to the pharmacy and it taking 24 hours plus to actually have it filled. And then, having the contact information for our local milk bank, and as well as reviewing their medical history for, obvious contraindications to milk donation if that's their plan. So we'd love to take any questions. And just finally, one final plug, if you are not registered to vote yet, please do register to vote. It does matter. Thank you. We'd love to take questions.
Thank you both for that presentation and for all the work that you're doing. As questions start coming in, I'm just struck by how recent all those laws are. It's just really telling how far we've come and how far we still need to go. There were a couple of things I was hoping you could just say again, for, I think, the pearls to take away. Dr. Crowe, if you could talk again about the radiology contrast and then sedation recommendations for pumping. I think that comes up a lot. So if you just like hammer that home.
Okay. So as we look at the contrast, I know in pregnancy, we often will not use contrast, particularly with an MRI, but the American College of Radiology recommends that lactation not be interrupted with CTs with contrast and with MRIs with contrast, that any kind of, and then when we think about some of this contrast is often given through the IV. And so something that's given intravenously is often not well absorbed even if it did get to the milk, and these low volumes colostrum in the first few days, but also later with higher volumes, even if it did get into the milk, it would be at a low enough level that it would not be significant to the infant. Sorry, I'm not
Sedation.
And then, sedation. So in terms of sedation, this question does come up a lot. Thank you for asking it. A lot of people there's a lot of people who may need procedures done and anesthesia, and there's the use of a lot of things that are immediately reversed after a surgery or after sedation. And so when the parent is awake and alert and able to interact with her baby safely, in general, that would be the time that she would be safe to lactate and to bring her baby to her or to express milk. And it's also really important, if the baby is not immediately available for various hospital reasons, they may not allow an infant in certain areas. It's very important that they have access to a pump in order to help prevent a mastitis that may develop if an extended period of time takes place when they have not been able to express milk. So very, very important for our post-surgical patients to have a hospital-grade pump brought to the PACU and help them with that immediately.
Great, thank you.
Thank you.
We have a few questions rolling in now. So Dr. Henkel, could you review the dosing and exclusion for cabergoline? Is it a one-time dose, and what exclusion specifically is psychiatric disease and exclusion?
Sure. So 1 milligram PO within 4 hours is how we studied it in a trial. Our contraindications were uncontrolled hypertension. That is really the one that is going to come up most frequently in the obstetric setting. And so someone has chronic hypertension, who's well controlled, normotensive on their PO med, they absolutely can still get cabergoline. But a new onset, pre-severe features, and that's like the reason that they are ending the pregnancy at 22 weeks, that would be someone I would not feel safe about giving cabergoline to. And kind of again, this is really just because of that history of strokes reported after bromocriptine. From a physiology standpoint, if anything, we see more hypotension events after cabergoline's use. So, if it's given, I don't, no one should be that concerned that harm was caused. Or I wouldn't necessarily think that a lot of extra monitoring is warranted. But because of that history and, I think that we need to be relatively cautious with our use until more data is out there than what I've published. Psychiatric comorbidities. Certainly, many kind of more severe, like schizophrenia, that level of psychiatric comorbidities are very much dopamine driven diseases. And those would also be people to consider withholding cabergoline. It is a one-time dose. And so there certainly are case reports of people receiving it and not precipitating any sort of mental health crisis, but it's worth a discussion. Definitely not an absolute contraindication.
Great, thanks. And then on the opposite of inhibition, Dr. Crowe, can you address medications for increasing milk supply?
So that's a whole different talk, but I appreciate the question. So most people who come to me to increase their milk supply requesting medication, most people can be treated and their milk supply can increase with counseling about increasing the frequency gradually. If they're giving formula, gradually slowing the formula so that their baby is hungry enough to want to feed more frequently, but not too hungry that baby's not growing adequately. So we do a lot of work on that in the OB clinic. The one group who may benefit most, in terms of medications that we have available to us that are FDA approved, Reglan is approved for use in the US, but it also, as we all know, has some significant side effects, and I'm not as comfortable prescribing that long term. But when babies are not able to feed directly, a baby might be in the NICU. That's the setting where sometimes I will prescribe medication. But there's a lot of counseling, like I said, that goes around that. I know breast lactation, breast chest feeding, it's very hard in that first month. And people I wish that I could give them a pill to make it easier. But unfortunately, we don't have a cure for that involves sleeping 8 hours at night, getting up and lactating during the day. Is not realistic. But it also, depending on psychiatric conditions and other comorbidities, sometimes that's what people need, and they need to really be congratulated on whatever milk they are providing. So that's the approach that I would recommend.
Yeah, that's great. Another question, maybe you both can address, but thank you for the talk. Have you had any patients come to you after having a baby with a gestational carrier? And maybe also, how would you counsel a gestational carrier who hasn't quite delivered? Breastfeeding is not something usually REI discusses. And so where would that occur and how do you approach that?
So I'm happy to see patients like that in the OB clinic. There is a lot of counseling that goes on around it because, again, it's not a perfect fix. Non-FDA approved is a medication called domperidone that does not cross the blood-brain barrier in the same way that Reglan does. It's not FDA approved because when used in high doses intravenously in the ICU, there were some adverse events. And so it's basically not available in the US. Many times patients come to me and they have already read about this and know that they want to use domperidone, which may be something that I'm more comfortable with than longer term Reglan due to the side effects of the Reglan crossing the blood-brain barrier. That being said, I do get an EKG, and I don't recommend its use because it's not approved in our country, but they usually will tell me if they are interested in lactating. They will say, this is what I'm doing. And then I say, well, here's the EKG and let's follow you to make sure that that's as safe as possible. But we also use oral contraceptive pills to increase the levels of estrogen and progesterone, just like the physiology of pregnancy. And then to initiate milk, we want to stop the progesterone. We want that to completely stop. And we use pumping alongside that. This has been, interestingly, some people are very responsive to it, but many people are not, particularly if they're postmenopausal and have never lactated. This can be an extremely difficult and frustrating experience. And I often give also the discussion of what the, if the gestational carrier is their partner, all the things that they can do to support that partner. And depending upon how important it is for them to actually lactate versus if they want to induce lactation to help their partner, we talk about all of the other things that they can do and all the time they'll, spend lactating versus helping. And it's a balance in terms of that, particularly when the couple, when there's a partnership there. And some people will hear that and get the realities of that and decide, I think I'm going to do everything else while my partner lactates. But other people, it's really important to them. We can also use a supplemental nursing system where it's like a little straw that's taped near the nipple, and babies can latch onto that and they can get the experience of lactating. Even if it's not long-term, that short-term experience of lactating can be very healing to some people. It can be very important to some people if they otherwise have not been able to carry the pregnancy and then now are wanting to at least have that opportunity to lactate. That's another option that is something that I discuss.
Great. And for the person, the carrier that carried the pregnancy and comes in after, maybe you can address lactation in that setting or inhibition of lactation in that setting.
And so I think that would depend on the discussion, if they're not partnered or even if they are. And I'll pass that to you.
Oh, I was thinking, certainly sometimes for gestational carriers, lactation and expressing milk for a certain period of time is part of the gestational carrier contract. And I certainly defer to my REI colleagues with that. But that is sometimes an option for people. And then from an inhibition standpoint, cabergoline would be a great option if they don't intend to express milk.
Any difference in the dosing at term? Sorry.
Nope. The 1 milligram was based off of term physiology. Possibly less could be needed in the second trimester, TBD.
And then if they are contracted to lactate for certain number of weeks, or months, I just discuss the weaning process also, because they abrupt weaning, so immediate stopping of lactation, can lead to some risks and inflammation and even mastitis that we would like to avoid. So because I don't necessarily use the cabergoline. Well, my question for Dr. Henkel, would you use cabergoline later?
It's not well studied. It's from a physiology standpoint, we think it probably works better for inhibiting, like preventing lactation from ever starting. There's very little data about suppression later on, but future area of study.
And we know that the lactation is very prolactin dependent in the early phases of lactation, and then later it's much less prolactin dependent. So it makes sense that it might work for a certain period of time, just based on the physiology, and that it might not be as helpful later. So that would be something to learn more about.
Great. One more about milk induction and medications, and then I have a couple other questions. What's the long-term use of milk-inducing medications? Months? Do the people have to keep taking it throughout breastfeeding, or is it only for a certain part of it?
It's a great question, and it's very understudied. As much of lactation is very understudied. The individuals who have previously lactated may not require a longer term use of any medication in terms of lactation. And then once lactation is induced by the pills and then the domperidone is introduced, or the Reglan, and the milk is stimulated, the OCPs are stopped, and breastfeeding lactation is initiated, Some people will not need to take exogenous medications at that point, and usually it's just simply one medication, either the domperidone or the Reglan. The Reglan is, like I said, I wouldn't prescribe it for longer than 2 weeks due to the concern for side effects. I have seen people use the domperidone for much longer and find that they do need it for much longer. But again, that's not FDA approved, and there's not a lot of good information or data for us to determine who needs that longer term versus who could wean off of that.
So the next question's about, has Baby Friendly made any changes to be more pregnant person friendly? I remember there were some negatives about this program.
So this is a ongoing discussion. This is based on an international organization, and it's interesting, if you speak Spanish, they use the word giving chest, dando pecho, to describe, but in the English language, although all people may have some mammary tissue, if not surgically removed, because of the associations with the word breast, it can give people some dysphoria. And we want to make sure that we're including everyone in the conversation. But no, it seems to be a very slow change. And so I would not, it's an issue. I also feel like it should be the family friendly, right? It's not just the baby friendly. And I prefer the word family friendly, because we want to be friendly to the whole family, the dyad, the partner, everyone involved. But no, that has not happened.
And then one more question. What does Stanford OBGYN do to support pumping residents?
So through the Lactation Council, through the recommendations, I would say even before that, our department has been very, very progressive. I know that the culture has certainly, I have seen the culture change even over the last 5 years. Residents have been more supported than ever. And in terms of lactation time, they are eligible to let us know to block time in any clinics. They can step away from clinics to lactate, to express milk. And they can, many are choosing to just use the portable pumps,
Wearables.
the wearables, and just pump when they want. And that's become very acceptable and not something that some people don't even notice. And I think that we've seen people develop their own plans for what will work best for them, and then really supporting it as a department. And it's been really amazing to see. This work review credit doesn't really apply to the residents. That being said, I know that even as we change the culture on a hospital-wide level, that will also trickle down to everyone within our structures.
I think also from a trainee standpoint, trainees are entitled to this time, and I think it does take some self-advocacy to use that time. And so starting the conversation during the day with the attending of, I need to pump 3 times, 4 times today, around 10 noon and 2, or whatever individual pumping time needs to be. And then if intra-op, tell as the surgery starts, like, I am going to need to scrub out at some point to pump. And I think it really is, many people just aren't thinking about lactation. And even like the most well-meaning faculty might not recognize that an individual is pumping and have that need. So, just a lot of communication, because I do think our department is friendly. And if there are moments where it lapses, more of a just kind of miscommunication or a lack of awareness. And I think that Dr. Judy is saying we should highlight that wearables don't work for everyone.
Thank you. Yeah.
Many people have more success with an external motor for expressing milk. So it certainly is not an expectation that people use a wearable pump. And also it's not an expectation that residents work while pumping. Some people will choose to do so, but that is certainly not required. Like, people should be relieved for 20 to 30 minutes so that they can go express milk throughout the day.
Yeah, thank you very much, Dr. Judy, for that comment. It's extremely important that we not set that as the expectation, but that we allow the individual residents to see what works best for them, and is least stressful for them. As the infant is older, and as time goes on through that first year or 2 years, the need to express milk as frequently decreases. But when people first return to work, at 6 weeks in particular, the need to express milk is very frequent. And so just to give you all that expectation.
Yeah, thank you. I think that's wrapping us up, and I'll just echo this comment of thanks for presenting this really important topic, and a reminder that we need to all be supportive of our patients and our colleagues, and you two just really exemplify that. So thank you for all the work that you do.
All right. Thank you all.
Thank you. Bye.